Welcome. I'm Diane Carbo with Caregiver Relief. Today's topic is addressing elder abuse in memory care facilities, a critical issue for vulnerable seniors. I always tell my clients that assisted living is the most dangerous of all our medical delivery systems. I know many people find that offensive, but you have to listen to my perspective. I want to explain why I feel this way, and I want to share some personal stories of my experience in assisted living and memory care units. I'd like to start by telling you about a time when I was a director of nursing for a very large and upscale assisted living with a memory care unit. I was also licensed to act as an administrator. I had an administrator's license for the facility when needed. When I say upscale, the type of facility that has the baby grand piano in the lobby, the dining staff the chefs wear the tall hats, and the wait staff wears the beautiful white crisp shirts and the black pants and shoes. The food was amazing, and the residents were happy with it. That's a big problem with everybody. The seniors want good food, and it's hard to find a place like that. And the residents were able to order from a menu. It was an absolutely beautiful place, but it was also the most dangerous place I ever worked. There were 5 DONs before me, that's director of nurses, and I lasted the longest. I was there for almost 90 days. What I learned and saw turned my stomach. This facility had independent living clients along with those that needed a higher level of care. So when I started at this facility, I felt overwhelmed. Let me explain. I'm an old seasoned nurse, and it takes a lot to overwhelm me, but you'll understand. It was my first day on the job, and I'm taking a tour of the facility, just nosing around by myself, when I had one of the residents in the dining room ask me to take another resident out of the dining room. And that is when I met John. John was in the middle stages of dementia. He was not placed in the memory care unit. And I think that's because at the time, nobody was paying attention in the facility at what was going on with him, and that he had an attorney that was monitoring him, paying his bills, but didn't check on him frequently enough, in my personal opinion. John had been a letter carrier as his career. That touched home to me because my dad was a letter carrier as well. But he was also an art collector, and I guess he must have done pretty well with his collection because this modest-looking man had amassed a very large fortune in art, of all things. So never judge a book by its cover. It was breakfast time in the facility. When I approached John, the stench was so very strong. So I went to him and I said, "Hey, I'm going to take you back to your room and I'm going to give you a shower and a shave." And we took breakfast with us. He was using a walker and he was shuffling along. And as I approached his room, one of the aides took me aside and told me not to go into the room. And I thought, why would you say that to me? And it was obvious that John needed attention. But when I opened the door, the smell was so strong. My first reaction was one of anger, rage, and disgust, not at John, but at the staff and the facility and what was occurring. This poor man lost his wife a few years ago. All he had was an attorney, as I said, that paid his bills. And what I found inside his room would make your skin crawl. And I want you to know, John's attorney was paying big bucks, at least $5,000 to $6,000 a day for this room. John was unable to provide care for himself. He was in the middle stages of dementia. His room had a bed, a table, and an electric chair, one of those nice fancy ones that you push the button and it helps you stand up. What I found in that room was dried stool everywhere, on his chair, his bed, his comforter, on the floor. And when I went into the bathroom to try to clean him up, I found a bathroom cupboard full underneath the sink of used, dirty toilet paper. I can't even tell you how brokenhearted I was for this poor man, that he was in this amazing, beautiful facility and nobody was taking care of him. It just, I can't tell you the frustration. So I took John down the hall and washed him, bathed him, and showered him in the community bathroom that they had. And I made the neglectful staff clean that room with the housekeeping crew. They had to do it together. I was so frustrated and angry that they let this occur. Then I had a come to Jesus meeting with the staff told me, and this is a common thing you're going to hear in assisted living and in memory care. John refused care and they could not force him. And I will tell you, this is a common problem in assisted living. If a patient refuses care, they will not make them, even if it may cause other health issues. And it does. This was another problem that I had with a client faced with her in-laws. Her mother-in-law had an adjoining room to her husband with dementia in another very upscale, top dollar place. From the day she moved in, she wanted to be waited on. She refused to get out of bed, refused to bathe, and refused to change even her underwear. When her daughter-in-law asked to please get her mother-in-law out of bed, get her bathed and changed, she was told that they cannot force her to do anything. This substandard level of care was costing almost $10,000 a month. They had 2 adjoining rooms, and the husband had a diagnosis of dementia. When I tell this story, I'm often asked, how could this happen? And it happens because assisted living is based on a social model versus a medical model. Now, here's another example that the staff in many memory care facilities has no knowledge of dementia nor common occurring conditions that negatively impact the health of seniors. I recently had a phone call from one of my clients. He was upset. He had a phone call from the memory care unit his mom was in. Her behaviors were becoming out of control. What was usually a sweet-natured woman was acting out, combative and argumentative, and it had gotten progressively worse over a period of a few weeks. They informed him they were going to give him notice that he had to find another place for her. Poor Frank, he was in shock. He was unprepared for this news. So he calls me up and asks me, what should he do? The first thing I asked was, did they even check her for a urinary tract infection? He said, I don't think so. So I suggested he take her to the emergency room, have her tested. If it was not a urinary tract infection or a UTI, I suggested he request her to be transferred to a senior behavioral health unit. The behavioral health unit would do tests and observe his mother for a few days. They may introduce medication if it was deemed necessary. This would give him a chance to check out other memory care facilities. And I did warn him that any person that has difficult and challenging behaviors is very hard to place. No one wants them. So I knew this was going to be a challenging situation for Frank. I got a call from Frank a few hours later, and it was determined his mom had a urinary tract infection. In fact, it was so bad, she was close to having sepsis. She had to be placed in the hospital for a few days for IVs. And I can tell you, any healthcare professional and many seasoned caregivers, family caregivers, know the first thing you check for is a urinary tract infection when there is any change in mental status or personality. Seniors don't always show the typical signs and symptoms of urinary tract infection. And I'm telling you, this is a caregiving tip for you if you're new to caregiving, or this is me being a smart aleck, or for those providing care in another setting, such as memory care. The distinction between a social model and a medical model, especially in the context of assisted living, is an important one to understand because you want to understand how care and support are provided for individuals, particularly the elderly or those with specific health needs. So, what is a medical model? The focus of the medical model is primarily on the diagnosis, treatment, and management of diseases and health conditions. It views patients through the lens of their medical needs and seeks to treat or manage these conditions through clinical interventions. Their approach in the medical model is typically problem-oriented. It aims to identify and treat specific health needs, often using medication, surgery, or other medical interventions. The medical model is usually employed in settings like hospitals, specialized care facilities, like memory care, and trained professional staff oversee the care of the residents because nursing homes have this model in place. There are federal and state regulations that facilities must follow when they have a medical model. There is lots of accountability, lots of paperwork, lots of documentation, and strangulating government regulations that are implemented in the nursing homes. Even with all the oversight, elder abuse and neglect still occurs in nursing homes. Trust me, I know. Professional dominance. In the medical model, healthcare professionals, doctors, nurses, specialists play a central role. They make decisions based on their clinical expertise and knowledge of diseases and treatments. The environment in a medical model is often clinical and structured around healthcare delivery. It's changing in the nursing homes, but it does include equipment, medical procedures, and regimented schedules focused on the treatment and management of health conditions. The primary objective is to improve physical health, manage symptoms, and treat illnesses. It may not always take into account the patient's emotional, social, and psychosocial needs. Although I can tell you that's really a very important thing that they focus on in care plans in nursing homes. And there are regulations that require activities and socialization to be available during the day. So you can go into most nursing homes or other facilities like behavioral health facilities, and you're going to see activities and socializations between the patients and the staff. So now I want to address what is a social model. The focus of a social model, particularly as seen in assisted living facilities, emphasizes the individual's overall well-being, including social, emotional, and mental health alongside physical health. This philosophy is incongruent with memory care facilities. Families expect those providing care will observe changes in their loved one and address the issues. Families do not realize assisted living is like having your loved one in an independent living center. If you need a blood pressure done, medications given, blood sugar checked, you have to pay a la carte for every service. And be aware, and you may find this offensive, but the same person serving you at the local fast food restaurant could be the same person giving your loved one their medications. In 55% of assisted living facilities, and there's over 300,000 of them in the country, there is a medication aide that has done a 4-hour training. And I can tell you, I have overseen medication passes and was very disturbed by what I observed. I have seen aides leave meds at the table side, but I will tell you, professional nurses are guilty of this too. And I have seen aides crush medications that were not to be crushed. The lack of training is responsible for 4 to 8% of medication errors. And I really think in assisted living and memory care, it's much higher than that, but it is not reported. And I can tell you that my perspective as a nurse of 50 years, the facilities don't care if the treatment or the medication was given. They just want it documented that it was. I really have an issue with that. I was on a forum that was for aides working in nursing home and assisted living. And one aide blatantly bragged she puts the medication she's to give in the needle box in the narcotics room. The stories I heard on that forum made me sick, and I actually had the site shut down, the forum shut down. I was totally disturbed at the lack of caring, the lack of understanding, and they didn't realize that they were setting themselves up for lawsuits and legal action. The approach, the social model, is more holistic and person-centered. That's what they tell you. It recognizes the quality of life is not determined solely by medical care, but also social interactions, emotional support, and personal autonomy. That's what they say. I'm sorry, this is not in line with the needs of the patients. If care is needed, home care is brought in assisted living. A person-centered care approach does not exist in assisted living, and it is non-existent in a memory care unit. Here's a perfect example. Dementia patients may wander and pace at night. If there was truly a person-centered care approach to memory care facilities, would have quiet activities for a person suffering from dementia in the middle stages of things to do when they're going through their sundowning process. I recently got a call from an 86-year-old female. God bless her. She called me to ask me for help with her husband. Her husband has been in a memory care unit for 4 years. He is 90 years old. This sweet woman was telling me her husband is starting to fall and she wanted to get a bed and chair alarm for him. She has seen many others fall in the facility, and it resulted in a hospitalization and an admission to a nursing home. A few resulted in death. This lady was told by the facility that they do not allow alarms, chair alarms or bed alarms in the building. And I told her, I'm sorry, but that's a facility rule. That's not a state rule, as they are they have no limited rules and regulations in assisted living. And I told her she could argue this. I instructed her to write and call the state ombudsman. I wanted her to CC the CEO of the organization, the administrator, and if there's a DON, include him or her as well. What I learned from this poor woman made my hair curl, and I'm going to address some of those issues she shared. I also have a few more personal stories to share. There is a greater emphasis on empowering individuals to make decisions about their own lives. The role of care providers is more supportive and facilitative rather than directive. To me, that's a huge issue because individuals with dementia are unable to direct their care, communicate their needs, and as they decline, unable to dress and eat without total support. The environment in a social model, such as in assisted living facilities, is designed to be more home and less clinical. It aims to provide a supportive community. I don't believe that. With opportunities for social engagement, recreational activities, and personal growth. Herein lies a huge problem. As a person declines, they need more and more assistance. The families must stay on top of things. The staff is not trained in medical situations, and they're not trained to observe and report a change in physical, mental, or emotional status. The objective or the main goal of assisted living is to enhance the quality of life and ensure the individuals are leading fulfilling and dignified lives. While medical care is provided by home care agencies, I encourage my clients to ask for a palliative care referral in assisted living. This allows the family to have an extra set of eyes on their family member, and I especially encourage it when they have a family member the family members are a long distance away. And I've got stories about that I'm going to share in that next few minutes. Assisted living as a social model. Assisted living facilities exemplify the social model. They provide a community environment where older adults or those with certain disabilities can live with a degree of independence while still receiving support for daily activities. These facilities focus not just on health, which I don't think they focus on at all, and safety, which I don't think they focus on at all, but also on enabling residents to engage in social activities, pursue hobbies, and maintain a sense of community and personal identity. Medical care is available, but integrated in a way that supports the overall quality of life rather than being the sole focus of the resident's experience. Therein, I have another problem. So let me go on. Assisted living facilities. Let's talk about navigating state regulations and improving resident safety. Now I'm going to get into the nitty gritty of what I really feel needs to be changed in assisted living, especially memory care facilities. The oversight of approximately 30,000 assisted living facilities in the United States is not governed by federal regulations, but rather by state laws. This leads to a varied landscape of regulations that do not align with expert safety and transparency recommendations. I recently read a detailed analysis in the Washington Post. This article highlights the significant disparities and how these facilities are regulated across the different states. Here's some key recommendations for enhanced safety and transparency. Experts and advocates have identified crucial requirements that could significantly improve safety and transparency in assisted living facilities. This is what they're recommending, and I'll tell you why I have an issue with this. Mandatory staff to resident ratios. Implementing fixed ratios for on-duty staff per resident is what they're promoting. However, mandates like this are rare. Only 13 states have specific staff to resident ratio requirements, while most staffs employing vague terms like sufficient staffing. And I will tell you why I have a real issue with this regulating staff to resident ratios based on numbers of residents. There are ways staffing can be addressed by staffing according to acuity levels. That means it's based on the needs of the client. I wish this would occur in nursing homes as well as assisted memory care units, but it's not happening. I told you I spoke to the sweet 86-year-old with the 90-year-old husband with dementia. She had complained multiple times about the level of care her husband was receiving and the staff. Every time she'd go to the administrator, his response is, "We're staffed at the state minimum requirement levels." The problem is there is no way on God's green earth that 2 aides can provide care to 25 residents with middle stage and late stages of dementia, because that level of care that they are paying for is not being provided. This lady was spending over $6,000 a month for care. Now, she sees her husband every day and stays for 5 to 6 hours. She makes it her goal to get there by lunchtime. This poor woman finds her husband still in bed with a strong smell of urine. He has not been given anything to eat or drink since dinner the prior night. He has not had any care because he wants to sleep. The aides, already facing unrealistic expectations of care, leave him alone. This is abuse and neglect that goes on unreported, and it occurs in every single nursing home and memory care and assisted living in this country. I know that's a broad and bold statement, but I have been in so many of them, the best ones and the poorest ones, and I can tell you it's an issue. Nursing homes also have poor staffing. When a government determines minimum staffing levels, They ignore the acuity needs of a resident. These laws, meant to create better working conditions and safer environments for the residents, has just the opposite effect. It gives the greedy corporations an excuse to provide substandard care while laughing all the way to the bank. Here is what every person needs according to nursing standards of care. A resident should be assessed at the beginning and end of every shift. Each resident needs personal care. They need to be taken to the bathroom, diapers changed, sedatives necessary. Some residents just need meals set up and food cut up before they can eat. Oral care, hair care, skin care is needed every shift. A person like my little 90-year-old man should be turned, changed, repositioned, and given personal and skincare provided. According to his wife, there are several wanderers with a high fall risk in the memory care unit. And when you know that level of care that is needed, you realize 2 aides on a shift is not even close to what is needed for the resident to enjoy a dignified quality of life. In fact, this level of care idealistically would have 1 aide to 3 or 4 residents. I know that's totally unrealistic. And I can tell you nursing home aides have 6 to 12 patients a shift. What is so awful. No one is getting quality of care. This is the issue I have is those with the ability to pay for the best possible care should be provided care congruent for what they are paying for. Now let's talk about dementia care training for caregivers. Requiring a minimum of 6 hours of dementia-specific care training for all caregivers is essential, and the minimum is not even close to what they need. Currently, training requirements vary widely across states, with less than half mandating such training for all staff and even fewer meeting the Alzheimer's Association's recommended minimum. And I can tell you the only thing that makes a memory care different from the rest of the assisted living is they lock their units. The lack of training is a problem. I have helped people tour facilities to find the right one for their loved ones. And I have been in many states and toured many facilities. What I have found is the majority of these facilities provide inadequate care in their memory care units, and the cost is incongruent with the level of care provided. I told you I spoke earlier about being a DON or Director of Nursing in an upscale assisted living facility with a memory care unit. Again, it was the most dangerous place I ever worked. One morning, I came very early. It was 4 a.m. I found the memory unit aide sleeping in the unit on the job. Since I had started that job, I had asked the organization to please send staff to help me assess the types of patients I have in the building. The request went unheard, and this was a national chain with lots of money. So I spent long days and I started, now this was a 350-bed facility. I started at the top floor and I started working my way down. And each day I would go into certain rooms where I left off the day before and introduce myself to each of the residents. This place was huge. And on this one particular day, I found a very sweet older man walking the halls. He told me he was getting some exercise. It was a lovely day out. And I suggested he should go outside and enjoy some of the evening before it gets dark. It was summer and it was still light up. He informed me he could not go far as his wife needed him. That day, I found that his wife was on hospice and he was supposed to and expected to provide care for her. Now, this man was a small, frail man that needed help himself. His wife was not able to get out of bed because she was incontinent and she was even unable to feed herself. He said in the evenings he had no help and was expected to provide care for her by himself. This man and his wife had fallen through the cracks. Now, that same day, I urgently was called to a room where a man had fallen in the bathroom. He was a big guy. He had a walker. He had become dizzy and passed out. He was diabetic, so I checked his blood sugars, and his sugar was sky high. A medication aid, we discovered, had discontinued his insulin. Oh, it's horrific. Now, the thing is, I don't know how this happened. There's usually an LPN, but in the evenings and night shift, there is a medication aid. Things do fall through the cracks, but he was placed in a nursing home after that, which was a perfectly preventable fall. I walked out of the facility that day because there were so many things that needed to be addressed, and their request for help from the corporate office was ignored. I was not going to put my license on the line because it was a very dangerous place to work. And it made me sad because the residents there over the 90 days or less than 90 days I was there got to know me, felt comfortable, and told me I was more interactive and more concerned about their welfare than any of the other director of nurses that had been there before. We also need to focus on online access to facility reports. That's something we have to advocate for. Providing families with online access to inspection reports and complaints would aid in making informed decisions when choosing a facility. Currently, the availability and the ease of accessing this information differs greatly between states. I want to discuss the problem of elopements and variable state responses. A critical issue in assisted living facilities is the phenomenon of elopements or walkaways. This is when elderly residents leave the premises unattended. Over the past 5 years, more than 2,000 such incidents have occurred in the U.S., with nearly 100 resulting in death. The response to this issue varies significantly across states, with some lacking measures to acknowledge or address the problem effectively. I was working as a consultant in an assisted living out in California that was taking Medi-Cal. That is the California Medicaid insurance program. These facilities that take Medicaid and function with Medicaid work on a shoestring budget. They take the patient's Social Security check as payment and a small pittance from the Medicaid system. The patients get $30 a month that they are allowed or permitted to use for luxury items. The food in this facility was an ongoing problem. I always thought in California they would have fresh fruit and vegetables, and that was not. I was shocked what I found. But I spent the night at the facility to work with the staff several times. I found the aide in charge sleeping at the front desk. Oh, Lord. One night I was there, and an elderly Asian man with dementia found a way out of the staff entrance. The staff noticed him missing at the change of shift the next morning. No one knows how long he was gone. The administrator contacted the police. The night shift started a search for the area. 4 hours later, the man was found about 2 miles away. God bless him. While he was found, because one of the aides was dropping her kids off at school, and he was in the school area, and she knew who he was. He had his walker, and the poor little fellow, his feet were blistered. He was dehydrated. He was confused. I think the thing that shocked me the worst was this is the second time he had eloped. You can't make this stuff up. So let's talk about the impact of regulatory changes on resident safety. Switching from vague staffing requirements to specific ratios can have a tangible impact. For instance, like in Mississippi, the implementation of a concrete staffing ratio led to a noticeable decrease in the risk of injuries and illnesses requiring hospitalizations among residents. I have a hard time with that one, and I'll explain, because the effect is even more pronounced in residents with dementia. Again, I'm going to tell you, I hate the minimum staffing requirements approach to care. It does not take into account the needs of the residents. It doesn't take into account the acuity levels of care that needs to be provided. We need to staff according to acuity levels to meet the needs of the residents, both in assisted living and in nursing homes. But I can tell you, in assisted living, the private pay patients are paying a fortune, and the prices they charge do not reflect the care provided or the quality of care provided. Now I want to talk about the training requirements and their importance. The level of training provided to staff, especially in dementia care, plays a crucial role in the resident safety. However, the extent and rigor of training requirements are inconsistent across the states. This inconsistency poses a risk as not all residents with dementia reside in specialized memory care units, underscoring the need for comprehensive staff training. State-by-state variability in transparency and enforcement makes a difference. Inspection frequency and transparency also varies widely. While many states provide easy online access to facility reports, others require public records requests, and a few do not release certain information at all. Additionally, enforcement levels and potential fines for non-compliance differ across the states as well, leading to an uneven landscape of accountability and resident protection. I have another story to share with you, and this just happened to me last week. It's just another disturbing aspect of the lack of transparency in assisted living. I recently was called by a client. Her daughter-in-law was called by her father's assisted living. She lives on the West Coast. His assisted living was on the East Coast. When Shelley got to the facility to clean out his room, she discovered his room was clean and neat. She also noticed a lot of things were missing. A very expensive watch, his scooter, his walker, and a few other things. His checkbook was also missing, and his locked drawer was opened. The envelope he kept cash in was empty. Of course, poor Shelley's in the throes of grief. She just lost her father. And as she's cleaning, the aides are standing around like vultures. They wanted whatever she was getting rid of. And to her surprise, when she gave it to them, they went out of the room his room that she was cleaning. They went through the stuff and they left what they didn't want on the floor for her to pick up outside the room. I can tell you this happens. I've seen it before. My client wanted to know what they should do about this situation. I told her, call the police. They need to investigate. And what they found was very disturbing. This facility was allowing some woman to come into the facility and take the belongings of residents that passed. She was taking their scooters and selling them. And she was taking their belongings to sell. And we also learned that this is still under investigation, but it sounds like this has been going on for years and nobody reported. Here is what I told them to do when they report abuse. I want to navigate the issues in assisted living, reporting procedures and guidelines. When encountering problems in assisted living facilities, this is in nursing homes too, or any facility, you do have repercussions and policy procedures you can follow to make sure that this doesn't happen again. It's crucial not only to report these issues to the facility management and the corporate organization, but it's also necessary to inform the state licensing agencies that oversee the facilities. And I also want to tell you that I take it another level. These facilities go through a certification. I can't remember it right now off the top of my head. But anyway, there's a assisted living certification facilities. And it's to identify that these are facilities that provide the best possible care. That's a joke as well. I'm sorry. 50 years of nursing, I know what's going on. I have the right to say that. When you're contacting the right authorities for abuse and neglect, in cases where there is evidence of neglect or abuse, as in this, you should also call Adult Protective Services, as well as the state licensing responsible for assisted living. And again, I say, get that certification. They need to lose that certification. It takes away any credibility. And additionally, you need to reach out to long-term care ombudsman in your area. In some states, APS staff handle the investigation of complaints. I always recommend that you also get the police involved. Don't count on the APS or long-term care ombudsman to investigate and investigate it properly. That's rude, and I shouldn't probably say it. It's probably politically incorrect, but it's the truth. Put it in the hands of the police. The long-term care ombudsman is federally authorized to investigate and resolve complaints on behalf of older residents in the long-term care facilities. But heck, I told this family, you need to go to the DA and file criminal charges against the facility. Let's identify the types of complaints to report. People are always afraid to do this, and it makes me sad because they need attention and they need report. And the facilities are afraid that it's going to be taken out on their family member by the facility. Let me tell you, that can't happen because that takes it to a whole nother level, and it won't happen. There is physical abuse. You have to report that. This includes any behavior causing pain or injury that is not accidental. I've seen aides intentionally drop patients because they didn't like the patient and he was acting out. I've seen aides give cold showers to people because they were screaming and they just didn't care. I've seen a lot of physical abuse and have reported a lot over my years. And I usually did agency nursing. I didn't belong to a facility because I was doing other jobs like discharge planning, that type of thing. But I always wanted to keep my hands on nursing. That was important to me. There's a lot of verbal abuse that occurs. Any conduct that causes mental or emotional stress needs to be addressed. There is sexual abuse. Violations of criminal sexual conduct or prostitution statutes need to be addressed. There's always exploitation, as I've addressed here in this audio cast. Illegal use of a person or their properties through undue influence, duress, deception, or fraud. Financial mismanagement, situations leading to potential exploitation and neglect. And this is the big one, both in nursing homes and assisted livings. I know people think because the assisted livings are nice and pretty, that can occur. But there is failure to provide necessary food, clothing, shelter, healthcare, or supervision. It occurs in memory care all the time because of a lack of follow-through. And I will tell you right now, even with government follow-through, it occurs in nursing homes, especially with residents that don't have family members. Documenting the details of the complaint. For effective handling of a complaint, it's important to meticulously record the details. Describe the incident. Document what happened in detail. Identify the victim. Note to whom the incident happened. Note the time and date. Record when the incident occurred or incidents occurred over time. Specify specifically where the incident took place. And identify who committed the abuse. That's abuser information. Responsibility for neglect. Note who was responsible for any neglect. And in the case of the facility that allowed someone to come in, take the resident stuff, that I feel that facility needs to be shut down. I really do, because the administrator knew what was going on. This lady said she took these things because the fire marshal came in and said the room was too small to keep a scooter. That's just blatant, outright lie. And when the administrator heard her say that, he came right out and said to her, "The fire marshal's here. I get a report, and that has never been reported to me." And I know these nice, fancy, schmancy, high dollar assisted livings address all that because they know that residents are going to need scooters. They're going to need walkers. They're going to need things. So they accommodate the hallways and the rooms to handle those stuff. So I knew that was a blatant lie. Being thorough and precise in reporting and documenting complaints is vital to ensuring that they are addressed appropriately and that residents in assisted living facilities receive the care and respect they deserve. Here's a conclusion, a call for uniform safety standards. The current state-by-state approach to regulating assisted living facilities results in significant disparities in resident safety and transparency. There is a clear need for uniform standards and stronger regulatory frameworks to ensure that all assisted living residents, especially those with dementia, receive the care and protection they deserve. And I know that government regulations are a necessary evil. My reason for saying that is the government policymakers are so far removed from the real world. These bureaucrats don't know what they don't know. While implementing what they call expert recommended measures, such as mandatory staff to resident ratios, comprehensive staff training, and improved access to facility reports, is believed to significantly enhance the quality of care in this facility, I have my doubts. I know the long-term care industry very well. The nursing home industry is one of the most regulated industries in the country. The staffing is awful and the quality of care is diminished with the minimum staffing requirements. There needs to be a change in the regulations to staff according to acuity levels in both nursing homes and assisted living, and especially in memory care units. Thank you for taking time to listen to me today. I'm Diane Carbo, RN with Caregiver Relief. If you're a family caregiver, remember, you are the most important part of the caregiving equation. Without you, it all falls apart. So please, learn to be gentle with yourself. Learn to be able to provide self-care to yourself every day because you are worth it.
Thank you for watching. Don't forget to hit that subscribe button and ring the notification bell so you never miss an episode of Caregiver Relief.